We've got Robin and Ray, who are going to talk about their psychologically informed environments and dialogical approach. Brilliant.
It's particularly ironic when you talk about pie charts, because PIE in fact is the acronym that we are using to describe a lot of what we've been working on the last 4 or 5 years or so. But for us, PIE means psychologically informed environments. My background as a psychiatric social worker for 20-30 years or so. In my early years I worked in therapeutic communities in the health service and later in community psychiatry. I've always worked in environments where we were trying to tackle mental health needs and mental health issues by working in a community setting, using the power of the group, the importance of relationships and engagement and getting involved to help people come to terms with and move on from the problems that brought them into psychiatric care. And therapeutic communities as a model, relatively well known internationally, were particularly valuable, it seems, for people with what we would now describe as having a personality disorder in medical diagnostic pigeonholing terms. Most people hate that term. We much prefer a term like complex trauma, which describes how people got the difficulties that they had rather than what category to lump them into. It helps to understand that individual. But the term that we're finding more and more these days, as we look about how services try and engage with those individuals, is that term complex needs. It's about how that person works with the world around them and how the world around them works with them. About 5, 6, 7 years or so ago, I was working with a group of people at Department of Communities and Local Government and the Department of Health on a government programme that was intended to try and ensure that people who were socially excluded would at least have a reasonable chance in life of getting into a job and housing, stable housing. That was the idea. And in order to identify what we meant by stable housing, they brought in me as a person who was kind of bilingual in housing and mental health. That was the idea. Because I've been working on housing issues for 10 years or so like that. And my job was to try and develop a data set that would quantify and produce the information that meant you would tell your outcomes after your inputs with a quantifiable set of people. So the quantifiable set of people we chose were people in mental health services, because there's data. And it was obvious to all of us who were working in this program that actually some of the poorest mental health and some of the people with the greatest difficulties were the people who weren't in mental health services. They were people so chaotic they wouldn't attend appointments, they would often have such complex needs. They would go to the drug and alcohol services who say, we've got to sort out your mental health problems before we could deal with you. They'd go to the mental health services who would be told you have to sort out your drug and alcohol problems before we can engage with you. Pillar to post, falling between all the nets. And the government was aware of this. But the programme that we were asked to work on was specifically about people in mental health, secondary mental health care. So a group of us started thinking, well, how do we go write a kind of additional bit to this programme, to this report, about how important it was to also address the needs of people who would be even more excluded if we just implemented this programme that cherry-picked, in effect, the ones who were already in secondary care and gave them faster access to housing and support. What might have been a codicil to a report turned into a separate document that was published by Department of Communities and Local Government and the National Mental Health Development. And it was often known as the complex trauma paper. It was the first paper that we knew of to actually start saying very, very loud and clear that on one hand there is a massive amount of diagnosable personality disorder, PTSD, etc. in the homelessness population, but also to say that actually the people who are working effectively with this population are the homelessness services. And what we found, what I'd found, certainly in 5-10 years or so before I working as a mental health social worker, was there was some absolutely brilliant work being done in homelessness services with the people that we in the mental health services, frankly, were failing to reach, failing to get to engage. One thing I have discovered is that there is stuff going on in the UK around working with services and meeting these needs. So far as I can see, we are ahead, far ahead of many other countries in doing this kind of work. It's something we should be really proud of and trumpeting. And at that point, I will hand over to Ray
Tag team. Go on. Hi everyone. I'm Ray Middleton and I work for Mental Health Concern and the Fulfilling Lives programme in Newcastle and Gateshead. And we work with people with over 100 people with multiple complex needs. So that's people who've got addiction problems and mental health problems, who are also homeless, who are offending, who are difficult to engage, who traditional services find difficult to engage. So that's the criteria of the people we work with. And what we do is we also have the job of learning from that work. So there are 12 Fulfilling Lives programs across the country funded by Big Lottery. And we're learning from what we find by having navigators try to navigate that client group into the system. And obviously, as we know, there's massive combination of health and housing issues there for that homeless population. And there's very large levels of trauma, as we know, within that population, and complex mental health problems. The other side of the job we have is to then try to change the system, which is a challenging part to have to your job descriptions. We're finding a number of different things, and we just had our first annual report. We found similar costings to clients, costing maybe £40,000-50,000 per client spent by the public purse, but to little effect often with this particular group of people with multiple complex needs. Where that group of people were actually turning up is homeless services, and often the majority of those clients are outside of statutory mental health services, even though they've got the most complex mental health problems, and they have complex physical health problems and those combinations. So one of the best practice kind of ideas in the country at the moment is this idea of psychologically informed environments. So we decided to pilot 3 psychologically informed environments in 3 services. So that was a homeless drop-in centre in Gateshead, and 2 rehab and recovery centres, units for mental health, which were residential, but they took clients who were in the psychiatric hospital. Some of them were homeless, and they would go to those units. And so what we did, and I'll keep it brief because of time, is we introduced psychologically informed environments, and the outcomes have been very positive in terms of this feedback from the staff, saying this really helped. But often people wonder what it is. So what we did practically is that I went in fortnightly and ran 90-minute group reflective practice with the staff. And I introduced a framework that I've written called Life's Ladder, which basically put a lot of psychological theory into a plain English framework which people could understand, and got rid of all the jargon from the world of talking therapies. There's lots of really good things there, but if you introduce a lot of jargon, it puts off the frontline staff. So you have to translate it into plain English, which I'm a big believer in. But to take the valuable learning from it, we delivered training to that staff group, and we introduced a framework. So you don't have to introduce the framework I did. With the PI, you could have a CBT framework, you could have a psychodynamic framework, but the idea is to have a framework of some kind to help the staff to start to reflect on what is the emotional wear and tear that's going on with them, because often in these services there's lots of trauma going on with the staff, experiencing difficult relationships and incidents. There's a lot of firefighting going on, and there's not the space opened up for staff to reflect and start to be think therapeutically about the trauma in people's past of their clients. And so you get a transformation going on through this. So every fortnight, 90-minute reflective practice, we introduced an approach, a dialogical approach. So in Western Lapland, they've got an open dialogue approach, which is a radical new approach which 3 NHS trusts in the UK are now piloting open dialogue from Western Lapland, which is a non-diagnostic approach, but it opens up the dialogue and values all the different points of view, including their client's point of view, their relatives. Professionals can have a valid point of view, but you're not saying that's the only point of view to value. What you do is create a safe space for people to reflect on the different ways to understand the complexity of the work they're doing. And so we have this dialogical pie, basically, and the feedback that we've got already from interviewing the staff has been really positive, saying it transformed the way they thought about the clients. Instead of thinking about them, for example, in a stereotyped way, that person's got maybe a label of schizophrenia or personality disorder, people start to see the narratives of their life, to understand the trauma of the past, and then to have better quality relationships with the clients. And as a result, the clients were doing better. We're also going to evaluate this using a social return on investment approach, and that's going to be done, and we don't know what we'll find out, but I'm hoping it will be reflective of what the staff are telling us face to face, which is it's really made a big difference, this approach. I'd say there are challenges to introducing a PI, so it's not a simple thing, it's more of a journey, I'd say, and there's lots of resources on PILink.net, which is a community of practice that Robin runs, and it's free to join, and it's a resource, and I'll put up a slide about it in a second. But what I'd say is, it's not a simple on-off thing, it's a journey where you maybe go from a difficult place of a service that is engaging with this client group, with multiple complex needs, with lots of health and mental health difficulties, where you get to another space further down, where you're going to where the staff are very acting therapeutically, reflectively, they're not re-traumatizing clients by evictions, and you know, I'm not saying that doesn't happen sometimes, but there's less of it. There's more therapeutic work, and the relationships are concentrated on. There were difficulties, practical difficulties. So the good news about introducing a PI into homelessness services, or accommodation-based services to improve the mental and physical health of clients, is that you can adapt it to the local situation. So when the staff couldn't go away for a day's training, and I did a film, which there's a link to it there, made a 20-minute YouTube film about what is a PI, what's a dialogical PI, that anyone can access and look at. And that meant the staff could actually, just adapting how you introduce the PI on a journey, which is co-production, and you're listening to what the staff is saying, and it's difficult. And we used a lot of new social media, so we're using something called, Periscope, using some live streaming plans for the training, but something called Blab, which is basically you can host your own live TV show, and we're experimenting a bit with that, which sounds a bit scary, and is a bit scary, but it is a way to bring people together. So Robin's been a willing guinea pig with this, to actually share good news quickly without having people travelling hundreds of miles to come to some training. And you can record these things and share the good practice. So I'll just put up a screenshot there of PILink.net, which is this community practice about more information around psychologically informed environments can be accessed there, and you can register to join it. These days, the good news is it's free to join. There's a huge potential, I think, to share and communicate between good practice within this area around multiple complex needs, but there's a lot of barriers. So there's the barriers of the difficulty of cost of travelling, and the busyness of the work, and the nature of the work. When you're working with people who've experienced a lot of complex trauma in their childhood, the nature of the services that do engage, there's lots of services that don't engage, and they need to change as well in terms of structural changes and having new approaches. So I think the future in mental health services is probably more about an open dialogue approach, I'd say, if you looked in 10 years' time. But at the moment there's a categorical approach, which is saying, people have different diagnoses, and services are geared that way, and that doesn't help people with multiple complex needs. But there are alternatives available, and I think that's likely to be the way things go. But I think the new social media can help a lot about sharing these good ideas. But usually, when the people are engaging, there's a lot of counter-transference. I've used a bit of jargon, but I'll try not to speak complaining. But what it is there's a lot of firefighting go on, and there's a lot of emotional wear and tear, there's trauma towards the staff, and so there's not the reflective practice, which is what the clients need. There's evidence-based for that, to help to get better, is they need to reflect. So the staff need to be looked after and cared about, and have compassion for themselves in order to be calm and create a safe space for the clients, so that those conversations become more therapeutic. Therapeutic just meaning something that helps you get better, which could include professional talking therapies involvement, but it could include lots of other things. It could be lots of different narratives can help. There could be faith narratives, people might become a Buddhist or a Christian, or there might be narratives around education, or there might be narratives. There's lots of different narratives that people can heal within, and it doesn't necessarily, it can include professional input. We want that to happen more, but we want to open the dialogue up to say, look, if you're interested in the client group with multiple complex needs, come and join the party, as it were. Invite people in and help us to communicate better. Create these spaces which we heard about here, where you can have open dialogue and people can admit the difficulties of the work, which often doesn't happen, and actually understand that there's a limit to what we can do. We don't know everything, but in this approach, we can learn from each other and they become more effective, and so the outcomes for the clients get better. And so we're hopeful that we can learn as we go along and adapt, and we'll tailor it to the different kind of services, because each service has a different starting point on a journey, and so you need that ability to tailor it, but there's also some other principles there in the pipe.
That's it.
Thank you very much.